I was not doing great at dating prior to going into kidney failure. And so I decided to go on Match.com, which, any of us single people not having luck with the dating scene is like, yeah, online dating, why not? Met this amazing guy. But probably a month before, I went into kidney failure. And so that first day I was in the ER, I was like, do I call this guy or not? Do I, subject him to what this future might be? And so I did. And he came rushing by my side, stayed by my bedside the whole time, proposed in the hospital 4 months later. I have video of me in a backless hospital gown and him looking amazing. And I haven't showered in like a month. And then we decided that California wasn't the right move for us. I was starting the transplant process at UCLA, and it was a 2-hour drive. I don't know if you guys know LA traffic, but it is like crazy on the 101. And so we decided to move back to Michigan, which is where I'm from, and started the transplant process at Trinity. And then my fiance at the time decided to get tested, and we found out we were a match on, I believe, Christmas Day or New Year's Day. And then 3 months later, we had the kidney transplant, successful. And then 3 months after that, we got married in California.
Wow.
And then 2 years after that, we got approved to try to have a baby. And so we ended up having 2 babies only because of that kidney transplant. Otherwise, I wouldn't have been able to have children.
Match.com has totally different meaning to you.
Oh my gosh,
multiple layers of like.
Welcome to The Summary, a podcast from Mary Free Bed, where we explore physical medicine and rehabilitation, one topic at a time. Together, we will gain insights, discover innovations, and deep dive into the latest developments in the field.
Doug, is it true today that we have a nephrologist in the house as well as an occupational therapist?
We have a nephrologist, which I don't deal with much, but there's a good reason, because March is National Kidney Awareness Month, so
Cool.
We want to do our part in providing some awareness of kidney health, kidney disease, but with our little rehab spin on it. We're focused on function and how does kidney disease affect daily functioning, and what kinds of things can we do to maybe help patients function better. So yeah, we have a nephrologist and one of our own occupational therapy assistants who has a history of kidney issues that she will discuss in a little bit. So we couldn't have a better group. I think we will start with Dan Meyer is a nephrologist here in Grand Rapids, and I feel like people in the rehab field don't know a lot about kidney disease. I know nothing. I mean, I had to go up and read a lot of things, and I wonder too, from a nephrology standpoint, how much focus is there on physical functioning, and what do you kind of see in your patients on a regular basis?
But before, I also want to say that Dan's wife is one of our physiatrists here as well, Dr. Aaron Bettis.
That's true.
That's how he slid in here.
That's how we got him.
Yeah. No, that's great. So, so I'm Dan Meyer. I'm a nephrologist just here in Grand Rapids, and I think this is a great topic. Actually, one of my biggest concerns is, especially for dialysis patients, quality of life is worse in a lot of situations, and I don't think we talk about it enough. And even coming to this topic, you'll notice there's some things I just can't answer, and that's kind of part of the problem. And it's great that we have Natalie here too, just for the patient experience, which again, we were just talking about how, it can be very different from person to person.
Yep.
But it's one thing, I interact with all these patients and I can see it, but it doesn't mean I can, walk in their shoes. So.
No. And me as a patient, even when I go into a patient's room that is on kidney dialysis, they have a different experience than I do. So I have to kind of go in there with understanding that they might not present the same way as me. They might not want to talk about it like I am. I'm very open about my journey, and some people aren't. It's more of a personal experience. So kind of understanding that in a therapeutic way.
And you've had quite a journey. Can you share it with us?
Yes, of course. So when I was little, they believed that I had strep throat that damaged my kidneys. The only really signs I had was protein in my urine and this urgency to urinate frequently, but no output, basically. So they ran tests and figured that I lost about 30% of my function of both kidneys. From then on, I just tried to live a very healthy lifestyle. And as all young people do, they move away from home and try to find a warmer climate. So I moved to California and really fell in love with personal training and teaching boxing. And so I got into that field. And because California is super expensive, I couldn't afford insurance. So I wasn't really able to keep up with kind of the progress of where my kidneys were going. And but I just, tried to stay hydrated, live a healthy lifestyle, eat healthy. And it wasn't until I was about 32 that I went into urgent care for just kind of a checkup. And they said, well, let's run a blood test. Just let's see how your kidneys are doing. And I went in and did the blood test, and I got a call. I want to say, and I could be remembering this wrong because it's kind of a blur, but I received a call, and I woke up at like 5 a.m. because I had an early morning class to teach. And I had this message that just said, you need to get to the ER immediately. And so I went to the ER, and I actually stood outside for half an hour because I didn't have insurance. And I was so scared about the debt I would be in, the medical debt I might be in because of this, that it took a call from my mom to basically say, get your butt in there and just don't worry about it. We'll figure it all out. So I went into ER, told them what was going on. They performed an ultrasound. They could not find my kidneys on the ultrasound. And so I immediately was admitted into acute care. Started dialysis and was doing dialysis every day because they were shocked I was still standing. And the only symptoms I had was fatigue, and I was biking everywhere and doing all these things. So I just thought it was just natural fatigue. And then I also was getting cramps. So I would yawn and I'd get a cramp in my neck, or I would like adjust my shirt and I would get a kind of a stitch in my side. And that was the only two kind of symptoms, I guess, that I was having. And I don't know why I didn't like correlate, maybe part of me didn't, because I knew that once I thought this might be my kidneys, that my life would change. And it did. I was in the hospital for about a month on, doing dialysis. They did a fistula, but it didn't work. So I went out of the hospital for a little bit and did outpatient while they tried to kind of figure out my dialysis regimen. So I was going to a clinic 3 times a week for about 4 hours a day. And they decided, or actually I got a blood clot in my neck. You can actually still see the residual from the port in my chest.
I was actually wondering. I can see.
Yeah, I know. I don't do steroids, I promise.
Well, no, I was worried about pulmonary hypertension or something along those lines.
No, it's just residual from a blood clot. So then I went back into the hospital. They put me on blood thinners. And then they decided to start peritoneal dialysis, which is having a catheter inserted into your peritoneal cavity. And so I went in for that surgery, and then I just had abdominal pain after the surgery, and I just couldn't get over it. And they're like, oh, it's just the surgery, you're fine. And I would say after several hours, I just kept being that squeaky wheel that we tell our patients to be, right, if they're feeling something. And finally, they did an ultrasound and found out I had internal bleeding. And so then I was in the ICU for 2 days. They had to bring me back into surgery, stop the internal bleeding. And then after that, I was able to kind of start peritoneal dialysis. So, and then side note, and this is going to be such a crazy segue, but I was not doing great at dating prior to going into kidney failure. And so I decided to go to unmatch.com, which, any of us single people not having luck with the dating scene is online dating. Why not?
Yep.
Met this amazing guy. But probably a month before, I went into kidney failure. And so that first day I was in the ER, I was like, do I call this guy or not? Do I, subject him to what this future might be? And so I did. And he came rushing by my side, stayed by my bedside the whole time, proposed in the hospital 4 months later. I have video of me in a backless hospital gown and him looking amazing. And I haven't showered in like a month. And then we decided that California wasn't the right move for us. I was starting the transplant process at UCLA, and it was a 2-hour drive. I don't know if you guys know LA traffic, but it is like crazy on the 101. And so we decided to move back to Michigan, which is where I'm from, and started the transplant process at Trinity. And then my now, well, my fiance at the time decided to get tested, and we found out we were a match on, I believe, Christmas Day or New Year's Day. And then 3 months later, we had the kidney transplant, successful. And then 3 months after that, we got married in California.
Wow.
And then 2 years after that, we got approved to try to have a baby. And so we ended up having 2 babies only because of that kidney transplant. Otherwise, I wouldn't have been able to have children.
Match.com has totally different meaning to you.
Oh my
totally
gosh,
multiple
Totally.
layers of like.
And I found that my story, like I wanted to do more than just, go through this. And I decided, kind of going through this process too, and realizing I didn't understand a lot about kidney disease and the transplant process. I thought you got a transplant and that was it, which a lot of times that isn't the case.
Or even just like doing dialysis. There's actually, a lot of people don't realize there's multiple options.
Yes.
And actually that can be really overwhelming. Initially, there's too many options and it's already kind of a life-changing event. So it's great to hear the actual patient's, your story. I shouldn't say the patient, you know what I mean? You're a person.
No.
But, a lot of the things you say, unfortunately, like are pretty common for people that just show up in the hospital in renal failure.
Yeah.
Just like a couple of things, for the most part, and I have this conversation with patients almost every day, just talking about how, it's never going to feel like a broken bone, even though it can kill you. And that's one of those things, usually the vast majority of patients with renal failure, they're going to die from cardiovascular disease. And that's a hard thing because people are like, I can't see anything. It's not this tangible thing. I mean, even when I talk to other physicians, nephrology is a very cerebral specialty. You have to do a lot of thinking, a lot of physiology. But for patients, that's really hard to say, like, hey, I don't feel that bad. And you're telling me if I don't start doing dialysis that I'm going to die? Mm-hmm.
Can we stop right there
Yeah.
real quick? Imagine that. A machine is keeping you alive. Mm-hmm. That is what is the only thing keeping you alive now. That idea of you are facing your mortality. Okay, it's physically draining, it is mentally draining, it is emotionally draining. It completely changes your perspective on being an individual, right? And I think what's hard too, and you can correct me if I'm wrong, but like you said, you kind of corrected yourself and said the patient, or you feel like a number. You really do, and it takes doctors and therapists and all of us coming into a patient's room or them coming into the clinic and treating them as an individual, having them be able to have that sense of identity still, because it takes your identity away.
I think that's actually right. I mean, even the infrastructure for dialysis has a lot of limitations. I mean, think about it. So, I mean, you did peritoneal dialysis, but so like for people doing in-center hemodialysis, the unit I go to has 36 chairs. There's not a separate room for them. They're sitting on a dialysis machine in a vulnerable state, and you're having sensitive conversations with each of these patients in a row. Yeah. And it has to be an efficient process because I'll be honest, there's a shortage of nephrologists. So the number of patients I'm seeing, it is not a humanizing experience. You actually have to, go out of your way to make it a humanizing experience. And, I think my experience in an in-center hemodialysis unit is actually what motivates me to do so much in my CKD clinic. And that's something, it's hard to convey that. That's why it's great for patient advocates, because the fear in the back of my head is I never want to see you on dialysis, because once you're there, very rarely can I get you off. It's all preventative. And, there's people who would give anything to get off dialysis. And I tell the time for intervention was years ago. We missed that boat. It's easy for me to be motivated, but for people who have not seen, in-center hemodialysis or don't understand, really how terrible of an experience it is, it's hard to get that motivation when you don't feel that bad. Like you said, at worst, at the very end, some fatigue.
Yeah.
And before that, it's not that dramatic for a lot of people, especially younger, if you don't have a lot of health issues. Mm-hmm. And it's not unusual, that description. I came in fatigued. You check someone's labs, their creatinine's 13. Mm-hmm. What's also shocking is the slow
that
burn.
Was actually what my creatinine was.
And I bet your hemoglobin was absurdly low too.
Yeah.
Some of these patients will show up with a hemoglobin of 4.5. 5 grams, and you're like, you're standing, and
it's just like so chronic that
yes.
People have like literally just dropped dead from kidney disease, not knowing they had it, because they had no symptoms, nothing, like no fluid retention, like I said, you're just feeling a little tired, or maybe you are not going to the bathroom, like you're not voiding as much. I think that's what I noticed too, is like when I would go to the bathroom, your urine starts to decrease. So your output isn't as, what is that?
And it's a weird thing to monitor too. A lot of people, though, if they do become swollen, it's one of these things that it's like almost cosmetic. Like you'll be like, it's kind of weird to put my shoe on.
Yeah.
But it's something you can go about your day. Like, that is weird. And you're going about your life. You got other stuff to do. And, in hindsight now you're like, oh yeah, like I saw some problems, but you didn't even know to look for those things.
Yeah. I mean, the day before I was teaching boxing classes and riding like 45 minutes on my bike, I would have never known that I was that, was right into renal failure, and so.
The interesting thing you mentioned too, your concerns about insurance or the finance, which is a big part of this. And, I've run into a few circumstances where it's not just that someone needs dialysis, but just advanced chronic kidney disease, and they're uninsured. And, once they start dialysis and once they're deemed ESRD on this formal document I have to sign and send, then they're usually, eligible for Medicare or Medicaid. But in some of these situations, I had these patients, I literally can't get medications into their hand. And it's like, there's no prevention. It's just saying like, okay, well, once you have to do dialysis, we can get you insurance so you can start affording some medications. And beforehand, we just limp by until a crisis hits. And it's, it's really, it's a really depressing thing that does happen.
So now I have a question for you.
Please.
When I was on dialysis, I had to take potassium and calcium binders. Do all people on dialysis need to take those medications? So
I would say not all, but the phosphorus binders, which I'll also say from what you see in a rehab perspective, people are always like not used to management of phosphorus. And it's usually not a concern in the short term. Long term is a problem, but the pill burden with phosphorus binders is immense. I mean, I have some patients taking, almost 6 to 8 tablets of phosphorus binders every meal. That's 24 pills. That doesn't include antihypertensives, a lot of the cardiovascular prevention. So,
and they're like
huge.
They're huge pills.
And most of them cause GI symptoms in 20 to 30%. So it's like a high adverse event.
And somebody that likes to snack like me had a problem with it because you just have to take it every time you eat, and you have like a renal diet is very restrictive.
Oh, it's cardboard. It's basically cardboard. Yeah.
And fluid restriction too. So that's the other thing you have to watch is how much fluid intake you're having. And that's inpatient. When you're in an inpatient setting here, you have to really make sure as a therapist that you're watching, are they on a renal diet? What's their fluid intake? Because you can't just come in and be like, oh, do you need some water? Because they might not be they might be tracking how much liquids they're getting.
Yep. Talking a little about fatigue, you guys mentioned. So you're not that fatigued initially, but then you have to go through dialysis, which a lot of patients complain about fatigue after dialysis. So how do you manage that? You're not fatigued. We're going to put you through this life-saving measure, and you're going to be really fatigued. I feel like would demotivate me to go through dialysis.
It's kind of funny, and I'd be curious. I don't know if you remember some of these symptoms. The first time, the way I liken to people, we're all wearing glasses. It's great. I usually liken to the first pair of glasses you get. Most people think it's usually happened quite chronically, and they've adjusted, and they just think it's normal. And they're like, okay, well, maybe I just didn't sleep well last night, and they brush it off. And it's really this uremia that's building up. And then, once you get them adequately dialyzed, a lot of them do perk up. Their appetite improves, energy levels improve. And it might be somewhat subtle. But it's kind of like you don't know it till you're there. And that's why I remember with my first pair of glasses is like, do I really need glasses? And I put them on. I'm like, oh, I couldn't see. But like you said, and surprisingly, people don't ask me a lot of questions about that. But it's like you're treating this chronic fatigue all the time with a treatment that one of the number one side effects is post-dialysis fatigue. It's like finding this perpetual fatigue with a post-dialysis fatigue, which is, I say the two number one complaints I get is going to be time on machine and fatigue. Because even if you talk about and they're somewhat related, meaning, if someone's so fatigued after dialysis, they can't do anything. The whole point of doing dialysis is so that you can live and do things.
Function.
And if you have such significant, treatment fatigue, even if you're not on the machine that much longer, the hours in the day are only so much. And
also cognitive fog is, I think, a big one, slower processing times post dialysis. It's really real. And so taking that in account when you're working with a patient and making sure that you're taking your time and you're explaining things simply, and you have to come at with just the right challenge when you're working with a patient on dialysis. I mean, like any patient, right? But you just have to take that additional layer into account with dialysis and also their schedule. Unfortunately, sometimes on dialysis days, they got to fit in that therapy here in inpatient, and they have to do it all right away. And then they have dialysis where they're on that machine for 3 to 4 hours after therapy. And then so the next day they're just wiped because they've had all that therapy chunk and then right into dialysis. So I would say I go in there and you kind of assess what their level of fatigue is, and you try to give them a therapy that kind of fits, like I said, that just right challenge.
I think that, I'm sure there's probably scales for like objective, fatigue that you could follow, but I'll say clinically going from room to room, it's just one of these things that's, it's also not as tangible to say like, okay, your fatigue's a 6 today versus, you know what I mean?
Yeah.
And you have to take the extra time to actually pull that out. And even as a nephrologist, I'm very numbers heavy, which means it's very easy for me to overlook quality of life concerns. That's a problem. Probably not just for myself. I actually think I'm a very good nephrologist, and I really care about this. But I'll be honest. I'm not perfect, and I think quality of life is something that we don't spend enough time talking about.
Yeah, for sure. Yeah.
And I would think if I had to come in 3 days a week and get hooked up, and I have this fatigue, I would not be real happy with my life, and I would think there's a lot of depression. Depression and fatigue kind of go hand in hand.
Yeah.
Do you think a lot of your patients are depressed?
Definitely. And actually, especially, I worry about this, especially at the initiation. Like, so I think anything with a chronic comorbidity, because we're not curing anything. You know what I mean? We're just managing it, and they don't always feel that much better. So I think depression is really rampant. And that can be a hard thing to settle out from uremia versus depression versus something else. But I'll be honest. I mean, I've had it's strange to think, but I've had patients, they self-discontinue dialysis, and we have a frank conversation, just like we are now. And they've been doing dialysis, and they say, Doc, it's just not worth it. And it's not that they're hurting terribly; it's just so exhausting that they're not living anymore. I think I used this phrase to you guys earlier, like you want to dialyze to live, not live to do dialysis. And when you do that latter, it's strange. You can have a conversation like this, and someone's just like, I'm done, Doc. And that's totally okay. And we talk about hospice for those patients. But, the fact that you can just have a conversation with someone 1 week and then, especially if they're neuric, usually, it can be 7 to 10 days later when they stop dialysis that they can die. Those patients do that, knowing exactly what we're talking about.
What are some ways to prevent or manage the fatigue or counteract it?
I'm curious. Yeah, go ahead, Natalie. Go ahead.
I actually want to come as an occupational therapy assistant on this point. I think pacing, modifying your daily activities, caregiver assistance is an important one too. Also scheduling activities appropriately. If you're having certain fatigue, you might not be able to go out on that shopping spree you wanted to do. We always say when you're starting to feel fatigue, that's when you need to take a break and not waiting till you're exhausted, till you hit that exhaustion point. So I think it's very important that they are really in tune with how they're feeling and then just being very realistic about what they can accomplish in a day.
I think something I focus on, probably the first thing I jump to is talking about there's different modalities. And most people in the United States do insulin hemodialysis. I think it's something like, it's over 80% of patients do insulin hemodialysis, and less than 20% are doing home therapies, be it home hemodialysis or peritoneal dialysis. And that's one of the biggest, I think, I shouldn't say selling point. I'm not selling something. Again, the terminology is not very humanizing, is it? It's like a commodity. I'm serious.
A lot.
Well, no, but you're right.
Yeah.
But that's a big thing I talk about is I think your quality of life is going to be better, and you're not going to have the post-dialysis fatigue. That's the number one thing. And then usually the second one's cramping. Those are the two big ones I talk about a lot. And then some of the other things we talked about is you start trying to tease out these things. Depression's a big one.
Can I mention something
Yes.
on that? I actually, and I know not everybody's the same, but I was so motivated to get a transplant and just to like stay healthy while I was on dialysis that I did not experience depression. It wasn't until after my kidney transplant that I experienced depression. And the reason being, it was because, okay, now I got the kidney transplant. I'm at kind of the so-called end, right? Because now this is it. This is what's helping sustain me. But what's going to happen now? Yeah. And now I'm kind of sitting there going, okay, I just got to stay healthy, but what's going to happen to the kidney? How long is it going to last? What does that look like? And then when you have a family or people that care about you, it becomes even more intense. So you have to remember that these people, they have lives. They have, these patients, they have lives. They have family members that care about them, and to take all that in account when you're treating, these patients.
That's great. I love you, but please jump in with these things because it's really nice to have like the personal story behind it. But certain things I look at for my dialysis patients is just looking at not just modality, but then just like quality of sleep. A lot of these patients will have either sleep apnea or actually something we don't talk about is a lot of them have pruritus, which can disrupt sleep and make people fatigued. Anemia is ongoing, can cause fatigue. A lot of them are on beta blockers for one reason or another, can cause fatigue. A little bit what I try to do is, you try to focus on one, and then if that's not helping you move to the next, it's kind of an empiric trial, which I love the word empiric, which means I'm not sure. Let's try making one change and see if you feel better. And then if you report you're feeling better, we're going to focus on that.
Mm-hmm. Anxiety is big. Mm-hmm. I actually have cameras in my home. I mean, we have them set up because we have small kids, but I double check that I took my medication, and I have a whole system on how I take my medication because I'm so nervous that I'm not going to take my medication, and then that's going to cause kidney failure or rejection.
You mentioned earlier that my life depends on this machine.
Yeah.
That would cause some anxiety.
My life depends on somebody else's kidney right now.
Yeah.
I mean, there's no cure for kidney disease, and I think people don't understand that. There's no cure. This isn't a cure. This is a treatment.
Yes.
Mm-hmm.
And so the more we understand that, I think the more we can come at it in a very therapeutic, very personal way. And I think the other thing, sorry, I'm probably jumping to something else, but
No, I love it.
I think the other thing we don't talk about is like caregiver burnout.
Yes.
I know for me, I was so nervous about my fiance going through this that I asked him like 10 times when I was in the hospital, are you sure you want to do this? You can walk away. I understand. We don't know what this looks like. We don't know how long I'm going to be on dialysis. We don't know when and if I'm going to get a kidney transplant. I would not hold it against you if you couldn't deal with this journey, And so a lot of patients, in fact, I was working with a patient on dialysis, and that was one of her worries. She was so worried about being a burden on her family. And that is very real. So caregiver education, making sure the caregivers are well taken care of, but also letting the patient know that you matter. Your life matters. You are an individual. This is something you're going through. This is not who you are. And coming at it again with that empathy and compassion is so important.
I think some of the dialysis centers actually do exercise during their dialysis or different therapy modalities. Is that common, and what does that look like?
I don't think so. So, I mean, as a part of talking, I think what we talked about earlier, I think it's very telling that, you guys asked some questions about specifics about how exercise relates to this. And I couldn't think of an example. And so, prepping this, I was looking at some research done there's a Patricia Painter. And the two interesting things. So one study was just kind of elucidating the problem, which is saying that one, they basically interviewed both nephrologists, dialysis nurses, and dialysis techs. Those are kind of the three clinical staff you're going to see in a dialysis unit, and it was almost unanimous among them that no one was aware that there is like a KDIGO or like a big guideline essentially telling us that exercise is important. Mm-hmm. None. I mean, I think some of it's, I think most of us in this room would say, it makes sense. Healthy living, okay, which includes, nutrition and exercise and adequate sleep. Those three big things is important. But we give it lip service, but we don't focus on it as much. And in the And then I found from this same author, some research showing that, like dedicated exercise can help improve some both objective and subjective, physical assessments, be that, gait speed or, sit to stand. But it is a little more complicated. This same researcher was looking at, you could show that doing a dedicated exercise program would improve these markers. But it'd be different. So for the low functioning dialysis patients, they would have a big benefit. The high functioning dialysis patients, you just think about a healthier dialysis patient, not as much benefit, which makes sense with mold therapeutics.
Yeah.
Lower ceiling.
Makes sense.
And then in at least the one research that I was looking at, there wasn't actually an improvement in quality of life, at least in that particular study, which is surprising.
Yeah, that is surprising.
And I bet that's not a unanimous thing if I dug deeper.
I would actually love to see occupational therapy be invited more into the setting of clinics in the dialysis clinics, as well as pre and post transplant, just because there's so many things, right? There's medication management, managing fatigue, independence with daily activities, caregiver education, caregiver burden, pacing strategies, modifications to just things that you love to do, right? So that you can keep that independence and keep that keep your life going in the kind of the direction you want it to go, even on dialysis. And I would really love to see that. I know when I was in school, I talked to my educators and they're like, well, you don't really just treat somebody on dialysis, it's usually comorbidities. They're there for something else, and that's kind of just, they're also on dialysis. But I would love to see it actually be involved more in-depthly.
And there is an interdisciplinary approach that just doesn't extend to therapy.
Yeah.
So when I round, I'll have a social worker, a dedicated dietitian, and then a nurse. So we have layers. We just don't extend it to therapies.
And I think, is it maybe like insurance?
I'm not sure. But I even today, I talked to my dietitian who, some of these, she'll do these, that's a huge topic, and a lot in deep diving into that, especially if patients aren't doing their own cooking or if there's a language barrier, just takes an immense amount of time. And, my nutritionist is, almost by definition is a great health nut. She knows all these things. And I asked her, I was like, are you talking to any of these patients about, exercise programs? She's like, oh, no, I think you said, talk with the doctor about that. And then I come around and I'm focusing on like, okay, what's your potassium? What's your target weight? And these other things. And it just doesn't jump, to priority one. It's not.
And you're so busy. You're seeing so many patients.
Yeah. Which is, I don't want to say an excuse, but the system.
Reality.
Yes.
Yeah.
Yes.
But, I looked at National Kidney Foundation on the website. They have videos of exercise programs, most of them just sitting. Yeah, they're pretty low-level exercises, but, and maybe these people can do some of that during hemo. I'm not sure. Well, and actually, they'll specify for each exercise. You can do this if you're on hemo, PD, transplant. So that can be helpful for, patients to look at on their own. We need to show them.
I'd be interested to see that. And I've heard of people trying, like in a dialysis unit, trying like a study where they try some simple intervention like that. But I'll say, so most insulin hemodialysis patients, basically one arm can't move. You got two 15-gauge needles in their arm. And no one appreciates how much blood goes through that fistula. So I've accidentally dislodged a needle when pulling back a blanket and the tape pulls it, and the blood shoots across the room. That's not an exaggeration. Actually. But, you got someone sitting in a chair. Again, this is the uncomfortable bit. You have to sit for hours in a position that you cannot move. So you got to get creative, though.
Yeah.
What about those like stationary bikes?
I think that's a great idea. So the research study, I said the dedicated exercise programs they would do doesn't sound necessarily just in the dialysis unit, but they would involve a lot of, trying to meet some of these low functioning patients like, okay, we're going to do chair-based exercises or stretching. And when we're talking about cardiovascular, we're talking about walking, and then kind of escalate these things as they develop tolerance.
Other than not being able to move your arm, any other things?
No, they're that's about it. And most of them it's just normal. They and again, this is very different from your experience.
Yeah. Is it so? It's okay that the blood pressure goes a little bit higher. It's okay that the heart rate rises a little bit. That's totally fine.
Not a problem.
Interesting. Because if they're there for 4 hours,
a lot of time.
that's what do they normally just watch TV?
So I was going to say, everyone that has like a TV, a lot of people will be on their phone. Some people will be reading. Those are, you got to find something to busy yourself with.
Dialysis unit that was part of where I was working for kids. They would Zoom into their classrooms at times, which is kind of cool. And I think that helps with the depression side of things too. They're staying involved,
Keeping a norm.
in school, staying as normal as you can be. Yeah.
Mm-hmm.
I like that too. Anything that patients can feel like doing that, they're empowering themselves, so they don't just feel like it's just another pill. Because sometimes that's what it feels like.
Mm-hmm. I always said it was a new normal, but there was something that I had to keep normal in my life. So what am I going to do that's still me, that takes me out of kind of what I'm going through, like that. And again, when I'm working with patients in their room, just talking to them about things that are meaningful to them and figuring out how we can modify to make sure that they're able to do those things they love to do,
Mm-hmm. Natalie, you've been through peritoneal dialysis, regular dialysis, renal transplant, and now you're in this career world of occupational therapy. Looking back all that time, is there something you would have done or wouldn't have done that kind of relates to your current function overall?
I wish I would have just kept up with my level, like labs. I think it's very important, early prevention, like you were talking about. I did get a biopsy done, and they were I'm going to say it wrong, focal
Segmental glomerulosclerosis.
Yeah, there we go.
FSGS. Yeah.
That's what I had. So, I got a diagnosis. I was on medication to help slow the to help the function of my kidneys.
Did they think you had like strep throat many years prior?
Yes.
That makes sense. So essentially what they're saying, so you can get like a post-streptococcal glomerulonephritis, which then now you had CKD, but who's going to do routine labs on an otherwise healthy patient with no symptoms, right? I mean, and then over time, there's this hyperfiltration injury. It developed probably over years that no one addressed.
And people don't understand that can happen with strep throat.
Right.
Heart, right, too? Can it damage
yes,
the
rheumatic
heart?
fever, yeah.
So that's one thing they're like, what, strep throat? I'm like, yep. So, it's I think I would have just kept on in labs, early prevention, so regular visits to your doctor. And that's why awareness is so important, right? So that we're telling therapists how to enter a room with a patient that is on dialysis, but also to the general public, right? We want to keep kidneys functioning because there is a shortage of kidneys for kidney transplants.
Yes.
Okay, living donors. It's so important that people, if they feel the calling, become a living donor, but also just getting your name on that driver's license, heaven forbid something happens to you, but that legacy that you leave of donating, a kidney or an organ to somebody else and saving somebody else's life is amazing, right?
Yes.
So there's that, but also just for, staying hydrated, like you said, eating healthy, staying active, going to the doctor, getting labs done. And then, if you're having symptoms, call your doctor. Don't hesitate to ask questions. I think a lot of people are nervous, right, to say anything to their doctor, or they're, sometimes, I don't know, sometimes they don't always get a close personal relationship with their doctor. So they're not thinking that they can email them or let them know what's going on, where I have an amazing relationship with my nephrologists. I send them Christmas cards and just updates on everything. They probably will tell you I contact them all the time because if there's one little thing happening, I'm like, okay, I have this symptom. What's going on? And they're like, you're fine. You're okay. So just being aware of your body, and if you're having something that's bothering you, go in. Get it checked out.
I'll just say the actual statistics, because we had mentioned this. So 9 out of 10 Americans with CKD don't know.
Yep.
And actually, one of the first things to do in the CKD clinic when someone's referred, the first question will be, do you know why you're here? And you be depressed to know how often. They're like, no, because they have no symptoms, right? And then we go through the whole education process where I tell them about this invisible disease, and so it's 9 and 10 don't know that they have CKD, and it's so prevalent. If you think about some of the most common, chronic conditions, 1 in 3 diabetics has chronic kidney disease. 1 in 5 hypertensive patients has chronic kidney disease. These are very, very high numbers.
1 in 7 U.S. I think 1 in 7 adults in the U.S. have chronic kidney disease. I believe.
It's one of these things. It's just so prevalent.
Yeah.
So prevalent.
Well, that underscores the importance of just awareness. I mean, everything you guys have said, I wasn't aware of. I'm a physician, and I didn't know any of this stuff about kidney disease. So it's,
And
as we go home and
Yeah.
talk to friends and family, that helps.
And the other thing I got all the time was, "You look so healthy. I would have never known." And I'm like, yeah. So it's like, I guess you can't judge a book by its cover, It's just, But yeah, it's like somebody walking down the street might have kidney disease. They don't know it, and they look perfectly fine.
Yeah.
So Natalie and Una, you guys have both had very significant medical issues in your lives. You're doing well now, but I just wonder how that experience has shaped how you, and I'm going to say it, patients, because their job is how you treat patients.
It sounds so simple, right? But I think just empathy and compassion. Just remembering, trying to think back on times where it was really hard for me, just emotionally. I mean, I still cry. I'm a crier. but I would cry just randomly thinking about, like, oh my gosh, what if this, what if I'm on dialysis for 7 years? Or what if this kidney only lasts a year? Or I still get like that. I'm going on 10 years now, and you'll have a patient goes, oh yeah, I had a kidney that lasts 10 years. And then you put it on yourself a little bit because you're like, ooh, mine's at 10 years. Okay, And so there's just, so I try to think, okay, the scariest times during my journey, what did that feel like? And what was I going through? And then so when I enter a room and they're having those same fears or slightly different, because everybody's journey looks differently, I try to just come in, active listen, and use my therapeutic self throughout the session.
Yeah, I think definitely I feel that way as well. I think the biggest, honestly, having a difficult medical condition or period, it's actually a huge advantage as a care provider, because like if I have a little kid who has a colostomy, I could be like, hey, look at my colostomy site, look at this, what I had, and you know how it feels. You can give them hope.
Yes.
And I think that's something that an advantage, honestly, that I have received by going through cancer myself. Yeah.
Literally saw a patient today who, we were talking about, like, she didn't feel that bad. Her numbers were not where they need to be, and we were having this conversation, and it was not going well. No matter what I said, we just weren't connecting. And she literally shut down the conversation by saying, like, you don't know what it feels like to do this. And I just had to say, you're right.
Yeah.
I mean, I see a lot of people that can tell me what they feel, but I don't know what it feels like.
And everybody's so different.
Yeah.
So even though you have the exact same diagnosis, what you go through and what you feel is so different.
And that's why if I share my story with a patient to kind of try to connect with them, I try not to take away from what they're going through, because they're going through something completely different, And so I try to remind myself that, and I let them know too, like, I don't know your journey, and I understand that your journey is unique to mine. This is what I felt like, and it's I just try to connect even with hospital stays, right? I mean, not being able to shower every day can get, so I think, being a patient and, for long stays helps me in that sense too, just being able to kind of go, I understand the frustrations of just even every day being in a hospital bed, and having to wait on somebody to take you to the bathroom, so.
What about post-transplant? What does that rehab look like, the recovery process itself?
Did you have any formal?
So I had and that's why I want to bring more awareness, because I really do feel like pre and post transplant there needs to be occupational therapy or some type of rehab.
Yeah.
But I didn't have any, and most people don't unless they have comorbidities or complications with a transplant. So I got out of the hospital within a week. My husband, and I love to say this because people are always like worried about donating a kidney. First of all, you have 2. They only take 1. Okay, so you're still fine. You can live off of kind of one bad one.
Actually, just the fact there. So anyone that donates a kidney is much less likely to develop an ESRD, end-stage renal disease, than an average person walking. I mean, part of that's because we're going to select donors that are healthier than your average. But the actual stats, from an average American, if you donate a kidney, you're more likely to not have renal failure.
Yeah, they do a lot of labs on, before they select the donor. They want to make sure you're not going to need a kidney down the line.
Yes.
So also my husband was out of the hospital in 3 days. He still runs marathons, still drinks whiskey occasionally, So I think these are important things to say, though, because people are so nervous about donating a kidney, And I think if more people understood that, you have a spare and it's okay if you feel the calling to do it. Just ask questions, we're here to help, but I don't think enough people really understand the donation process, and because I feel like there would be more people donating if they knew.
Mm-hmm. Natalie, you kind of talked about you didn't get any rehab. You hope you had some prehab and post-rehab. What would that look like in an ideal world for you?
I think just managing my medications would have helped. Energy conservation, the things we do here with a lot of patients. I mean, it's pretty standard, right? Like, how do we need to modify you getting dressed, in the morning? Or what does your workouts need to look like so that you're not getting overly fatigued? And how can we do it in a way that we're slowly progressing in a healthy manner and we're not just okay, out the door, let's run a 5K, I think that's very important, But yeah, medication management's a huge one. I mean, especially if there's any cognitive deficits, making sure they are going to be able to manage their medications or somebody is going to be able to manage them for them. So, but yeah, I think it's very important that we, further studies are done. I would love, I know I talk to my teachers and they're like, first get into the field and learn more, which that is what I'm doing. But I would love down the line to do a trial of pre and post transplant, rehab and see what that looks like. And
I think few people realize the scope of what OTs can do.
Yeah.
When you mention all the stuff that you've mentioned, people don't think about that.
No.
They think about working out hands and stuff like that and dressing.
I mean, this is going to be probably a little too much information, but I think when I was in school, somebody said, "Oh, you help people wipe butts." And yes. I mean, that is one of the things we help do, but we're so much more than that, Even just a therapeutic listening ear, right? Active listening is so important when you're working with somebody and really understanding them and what they're going through so that you can approach therapy in the right way, But I mean, we work with everything. We want them to have as much independence as possible and feel like they can get back to feeling like themselves.
I just feel like a therapist too can spend a lot of time and come up with a really individualized plan because you have to realize end-stage renal disease, it's the common denominator, but there's so many different paths in stage renal disease. It is not the same journey for everyone. And so what works for one person is not necessarily going to work for another.
Yeah. Well, and you have polycystic, kidney disease, and so just so many different ways that they have to come at different surgeries or different treatments, so yeah.
But yeah, I don't think at least I'll say professionally, I haven't talked about a lot of rehab, after a transplant. What we talk about, it's shocking how fast the physiology changes. How many medications stop, or even when they talk about when the kidney is actually transplanted, like in the surgery, it pinks up and immediately starts making urine, and all these electrolyte imbalances we've been working on for years just melt away. But like you say, it really isn't a cure. It is changing one problem for another. It's just the transplant problem is much better. I mean, you still have to take anti-rejection medication. You still take a lot of medications. I
actually went in rejection a couple weeks after. So they put me on Dialysis.
Yeah.
And it's an IV medication. It's kind of an alternative to, I forget which one, Cellcept or
usually in place of the Prograf.
Yeah.
Like they'll do low dose Prograf and use belatacept as it's a little bit softer on the kidneys. Yeah.
So I didn't understand that. I think there's a higher chance of rejection.
Yeah, there is.
So I, if it's out there, I get it. That's just what I understood. And so I was back in the hospital for a week, and they had me on steroids. And so now I do have to take prednisone, just a small dose of prednisone to kind of make sure we kind of keep everything.
But your
even
husband
keel.
didn't feel rejected, right?
No.
Good.
Well, the one thing he always tells me is that if we get a divorce, he gets the kidney back. And I said, honey, I don't think it works like that. Don't think they're going to do that. So,
Different kind of chain. Well, this whole discussion has been very eye-opening to me, and I hope for our listeners, because again, in the rehab world, we don't talk about kidneys. We don't like real medicine. We like muscles and bones and stuff. So it's good for us to hear this very common problem.
Yeah.
And some of the issues that go along with it. So I think we couldn't have picked better guests for this story, and I'm glad that we can provide some awareness of kidney disease.
I'd love to say it really goes both ways too. I think there's a lot of improvements we could make for my instead of dialysis patients, I'm gonna say my dialysis people. Okay. I love raising awareness, and I think there's a lot of room for new ideas to manage the things we do, because we have by no means perfected it.
Mm-hmm. Mm. Is there anything as a PM&R physician, like as a nephrologist, that you would want PM&R physicians to know?
I think probably I can't say there's one specific thing, but just because it's an topic that you might not be familiar with, I don't want to shy away from these patients. We need you guys, and I think for the most part, I would say quality of life decreases every single time with dialysis, and so anything we can do to make patients' quality of life better, that is actually their number one concern. Most of the things I'm talking to my dialysis patients that I'm really passionate about, I think this is the primary problem, is not going to be the patient's or the person's main concern. And anything we can do to improve their quality of life, that's great.
Yeah, quality of life is definitely our specialty. Yeah.
Sounds like more research is needed.
Absolutely.
Always.
Yep. With anything, right, though? I mean,
Yes.
with anything.
Yes.
Yeah. Well, thank you so much, guys, for
Thank
coming
you.
on the
Thank
show.
you.
We
Thank you
really
for including
appreciate
us.
your insight.
Yeah.
Yeah.
All right. Take care.